Good afternoon, everyone. Thank you, Dr. Santosh and Sukran for joining the webinar. Sukran, please, shall we start with the webinar?
Yeah, we can, sure.
Over to
So,
you.
yeah, it's a pleasure to welcome you, Dr. Santosh Pai. I'll just give
Thank
a
you.
brief of, I would say, the host this side to all our guests who have joined in today. Right, Dr. Santosh Pai is a senior nephrologist and a professor of nephrology at Enapoya Medical College, and is also a part of the faculty at Chinmay Hospital, Karnataka. He
Mm,
holds an MBBS degree from VIMS Bellary and DNB qualification in both general medicine and nephrology with advanced training from Nizam's Institute of Medical Sciences in Hyderabad. Sir has been instrumental in building the nephrology department at Enapoya, which started with, I would say, 2 beds and now probably offers around 21 dialysis stations, offering services including dialysis, renal biopsies, plasmapheresis, and renal transplant. A respected academician, Sir has authored multiple publications in reputed national and international journals. Uh, Dr. Santosh is also the associate editor for Archive of Medical and Health Sciences. He is a frequent speaker in national conferences, actively contributes to education and capacity building in nephrology. We are delighted to have you with us, sir. And
yeah,
I am
Thank you.
100% sure that the experts' insights that you will bring to our dialysis guests and overall, I would say, the participants today in pain management for dialysis patients will help them in improving their quality of life and also the practical approaches that they can probably improve on. Please, sir, the floor is yours. Please take lead,
Yeah,
sir. Thank you.
yeah. Thank you, Sukran Singh. Very much happy participate in such academic talks actually, and very thankful for NephroPlus who gave me a opportunity to talk on very neglected topic, that is pain in dialysis patients. Actually, we encounter so many patients with pain, and many times we just forget how to address it. I'm really sorry, my voice is a little bit rough. I don't know for what reason today, but I think I should be audible to everyone. And any doubts or anything, I'm really happy to answer everyone's question. First, I'll run through few slides just to give a idea about pain management or pain in dialysis patients. And after that, probably any doubts or any questions, I will be happy to take it. Okay? Yeah. Can you share the PPT? Yeah. Next slide. See, pain among our end-stage renal disease patients, if you ask, actually, it is more to any patient who is on dialysis, or we call them guests in NephroPlus. We usually see a high prevalence of pain in one or the other way, and the assessment almost the prevalence what we have calculated is more than 70%. I would say almost 100% people are in pain in one way or the other way. So why we should address this thing is of most importance, because pain throughout their treatment or throughout even when they are not on treatment gives a poor quality of life. See, imagine we ourselves being in pain for a long time. It definitely gives a poor quality of life, and studies have shown that it has led to a poor survival also. Okay, next slide. So, understanding pain in CKD patients. Majority of the time, it's not only limited to our dialysis guests, or it can be in patients who are prior to dialysis, that is in CKD 3 to 5. Also, we find some incidents of this pain. So, broadly, we classify according to the what you say. Origin of pain. Mainly, we have musculoskeletal pain. The reasons for that is brittle bones because of osteoporosis or osteoarthritis, or specific to CKD patients like osteomalacia or high turnover bone diseases. Because what happens is in patients who are on dialysis or those who have CKD, what happens is vitamin D is not absorbed in their main diet. And because of that, the parathyroid hormone, which is present, it is secreted more. It's called a secondary hyperparathyroidism. And because of less vitamin D, the bones or the body suggests that calcium is less in the system. So they leach calcium from the bones. That's why many patients get musculoskeletal pain. The second type of pain is neuropathic pain. Might be because of the cause of CKD like diabetes or per se because of renal disease. They might present to you like a burning thing or a tingling or a shooting pain. Then we have abdominal pain, most commonly seen in patients on dialysis, also because of gastrointestinal issues like gastroparesis or constipation, not passing motions properly, or because of gastro diseases like GERD, that is reflux disease. And it is one of the most common discomfort whatever guests uh, what you say feel. Then we have chronic pain syndromes like fibromyalgia or chronic regional pain, which may coexist with the chronic kidney disease. Also, we have dialysis specific pain because of needle insertion repeatedly, probably thrice a week or twice a week, who are on dialysis. They may have a fear of pain because of repeated needle insertions and also because of muscle cramps. This is one of the most common pain what we see in dialysis patients, that is muscle cramps. Because what happens is if they are non-fluid compliant, and we have seen in our peripheral centers, all of the patients, when they come to dialysis center, they more than the clearance of waste materials are focused mainly on water removal. What they feel is you remove more and more water, they can drink little more water, especially on those days which falls on a weekend because of an extra day in a week. They'll have 2 days of gap. So what happens is they try to remove more and more water, and they get cramps. So these are few of the types of pains what our patients experience. Next slide. Can we go to next slide? Yeah. The sources of pain, as usual, as I've already discussed, most common is musculoskeletal. You will find it around 62%, including cramps, including what you say, bone pain or etc. Then around 13% of them will have gastrointestinal. Some people will have genitourinary complaints, like probably because of their native kidney disease, like diabetes, probably renal stones. What happens is we always forget when they have such pains. We feel, however, the patient is on dialysis, we may not be related to genitourinary, but that itself can present as pain. Then hematological or oncological. Hematological, like what I said, when we insert needles. Then even diseases like peripheral vascular diseases because of rapid atherosclerosis or in kidney disease patients, they'll have that pain. Then peripheral and central nervous systems. Many patients have comorbid illness like the stroke or peripheral vascular disease, which definitely causes pain in their lower limbs or half of their because of the stroke. Then we have chest pains. See, many of the time, what happens is during dialysis, patient will tell he has got chest discomfort or chest pain. Sometimes it might be because of a new dialyzer we used. It is called as first use syndrome. Or sometimes what happens is what you say because of in some dialysis center when we reuse, because of the chemicals present which goes into the body, they can have such pains. So or they can have a hidden heart disease. So these are the types when we classify the sources of pain. Next slide. Now I have actually made a diagram where the provider, the patient, and system, how this pain topic is not addressed properly. Now, when it comes to the provider in sense here is a doctor in the dialysis unit or the nephrologist. Problem with us is because like how we discussed, around 10 or 15 causes of pain. We have a minimal training in how to tackle it. For example, musculoskeletal. Usually, we feel either go to a spine fellow or go to an orthopedician or go to a neurologist. And per se, how to manage that pain, we may not be knowing. Sometimes cardiovascular, sometimes so the like any other topics in nephrology or related to patients on dialysis, we lack the ownership of pain management. We usually try to outsource, go to multiple systems, and we are not much familiar with safety, efficacy, and dialysability of medications, whichever we prescribe. Usually, we try to give less medicines for the pain because because of the fear of non-dialysability of medications, and especially opioids. We are very afraid because they might get addicted to opioids. Opioids may not be removable in dialysis. I actually had one patient whom had prescribed a small dose of pregabalin, and the patient slept for 4 days. And all this attended, how much ever we did a scan or brain scan, everything was normal. We dialyzed him also, but he was in deep sleep. And we lost so much of this thing on waking him up. After 4 days, when probably everything went away from his body, he got up normally. So just one tablet for in one patient can cause such kind of havoc. So we are always hesitant to prescribe such medicines. When coming to patient, multiple etiologies and types of pain, because if you ask properly to a patient, he will tell almost all pain is there in him, starting from chest to abdomen, musculoskeletal. So each pain is dealt in different way. With that, he might have coexisting psychosocial symptoms like depression or anxiety. So that is another one problem. Then fear of addiction to drugs. Many patients tell me, sir, please don't give painkillers or opioids such that we should not get addicted to drugs. Also, already our patients will have so much of tablets, and on top of that, you add these tablets, probably it will lead to polypharmacy, and then its side effects are not much known. Plus, time also. Every alternate day they are on dialysis, going to a doctor or multiple branches, getting an opinion how this pain comes. Probably time is also not much. Then the system. See, what we do is we don't see a patient in a holistic way. That is what exactly the patient in probably in oncology setup, patients who have cancer, it is slowly building up. Something like a palliative or pain management thing. But I think it's high time in nephrology also we start such a holistic way, like what you say, give an what non-pharmacological methods. All these things should be studied well and given in under a single roof. Okay, next slide. Now, why we are much bothered about pain? See, the pain can be acute to chronic. Acute means sudden in onset. Patient was all right, and suddenly he starts getting pain, and it doesn't go well, and it interferes in his day-to-day activity. Now, why it is important? Because pain is very protective and well adaptive for all organisms against potential injuries or events or actions. That means if you have pain, it might be suggesting something is wrong, might be a very trivial thing, or to an extent which might be life threatening. So we should actually address in a proper way, and mechanisms to allow for the persistence of pain beyond the healing phase can lead to chronic various pain syndromes where the patient might get maladaptive to that, and might land up in much difficult problems. So what I want to suggest is, pain is not simple pain. It might be showing you a trailer of a bigger problem which is hidden. Next. Now, how pain is sensed? So, we have so many receptors on our whole body, might be inside our body or outside our body. We just classify. Uh, these receptors are also called as nociceptor receptors. Now, I have put this because each pain is different, because and the way it is generated is also different. So, we should handle it also in a different approach. Not that you give painkiller to everyone, he may not respond to that painkiller at all. So there are so many mediators like prostaglandin, serotonin, bradykinin, substance P, and so many things are not even what we say, not even addressed properly. But how can this nociceptor be stimulated? By a mechanical thing. Just imagine we tie a band tightly to a patient after dialysis. Probably it might be a trigger. Sometimes thermal, water might be hot or cold, the extra sensation of what the patient might get. It might be relatively cold, but he might feel it is very hot. Then chemicals. So many chemicals are there which stimulate nociceptor receptors, and also inflammatory from within. If there is a small infection, it might trigger a inflammatory tsunami which can cause pain and may not end. Okay, next slide. Now, this is a pathway. So, already, I think everyone can see these are all nociceptive receptors and how inflammatory cytokines trigger it. And these are the nerves from starting from the spinal cord, how it goes to the pons, and at the end, it is processed in the brain. So, why I have put this? Because anywhere in this system, we can tackle by giving medicines or by any other way. We can just try to manage the pain in different ways. Okay, next slide. This is our brain, and how it is represented. See, a part of the brain where the legs are represented. The face is, even if the face area is small, it is represented in a very big way. The tongue might be very small, but it is having a huge representation. So, small problem inside the tongue, small ulcers will give you a much bigger pain. Small things in your hand or nails will have a much bigger pain than the whole limb. Limb may not have much representation. So even smaller things, eyes, even if the small area is very small, but in the brain it is represented in a very bigger way. So any pain which lasts more than 3 months is thought to have, means we feel that the patient is having a chronic pain. Next slide. These are the different types in which our patients tell what type of pain we have. Dull, achy pain, or chronic throbbing headaches, or associated with some symptoms like nausea, vomiting, or diffuse muscular pain, stiffness, fatigue, sleep disturbance, movement or jerky movements during what you say sleep, throbbing, shooting pain, sciatic pain. So all these things should be charted and seen which probably type of nociceptor is involved, which pathway is involved, because different drugs act in different way. Next slide. How to split it? Now, say everyone says we have pain. It might be a minimal or it might be big pain. How to do it? So many places we have different types in which we rate the pain. One of the major pain rating scales are, it is also called as McGill Pain Questionnaire. Probably we should have this type of questionnaire kept at least once in 2 months or 3 months. Patient should undergo this test In sense, it is a questionnaire which lists around 20 groups of words to describe the rate and intensity of pain. For example, sensory qualities. How is the pain? Whether it is flickering, whether someone is pinching, whether someone is pricking, whether it is itchy, whether it is dull. So it gives where the root cause of the pain is and its effects. So you have experienced the pain. What does it cause? Whether it is tiring, whether it is frightful, whether it is vicious, or it blinds you, it irritates you, it frustrates you, then overall evaluation, it becomes so annoying or intense. Sometimes patients cry because of pain, unbearable pain. So all these things, whether the pain is radiating, whether it looks like tight, or whether it feels your limbs are numb, all these things. So many patients vomit also because of what other symptoms involved with the pain. So this questionnaire has the score of 78 points. If the more are the points, more are the pain. So that gives you a rough, what you say, evaluation of how the pain is affecting the patients. This is one of the most advanced type in which we can question them. Next slide. Next slide. Yeah. No. Previous one. Yeah. Many patients or guests may not be knowing how to explain their pain, especially pediatric patients and those who have a poor verbal communication because of their other, what you say, comorbid illness. So for them, we can give something like this Wong-Baker pain scale from 0 to 5. If you show these faces and tell where to point, for example, 0 means no pain, 1 means it hurts little bit, 2 means hurts little more, 3 means hurts even more, 4 means it hurts a lot, and 5 means it's hurting so much. So this scale at least will give us what you say, a relatively better picture of what the patient is undergoing. Next slide. The third, if we feel that the first scale or the second one was a little complicated, the best one is the numerical rating of scale. For example, it shows 10 points, subjective thing. You can tell the patient from 0 to 10, what is your pain? If it is 0, means there is no pain. Less than 5, probably moderate pain. When it goes up to 10, that means you should intervene. It's a worst possible pain what the patient had got in his life. Next slide. Now coming to pain management. So we have discussed now what is pain, why is it important, how patients present, and what are the pathways, what are the nociceptors, everything we have discussed. Now how to rate the pain. Now how to manage. So it is a multidisciplinary approach. Initially, we give more of a non-pharmacological interventions, then probably going towards a pharmacological interventions, depending upon the rate and severity. And the selection of specific therapeutic modalities depends upon duration, etiology, and intensity of pain. Not only the doctor involved, probably the patient and other disciplinary thing also help we can take. Especially we involve more of our social workers or those people who are trained in pain and palliative department can also be involved. Most commonly, what we do if the patient is having muscle spasm, pain after going after a dialysis, we try to apply a topical thermal therapy like hot water bags, rubber bags. They can apply such that the pain gets relieved. Many of them we put ice packs. So each person is different. Some people will get benefited with the topical thermal therapy, especially those who have peripheral vascular disease. You should be very careful, especially in diabetic. You can't many patients have come with the hot water bag with burns because they don't realize that that pack is hot, means the intensity of the hot may not be reliable. So many times we give cryotherapy. That also can cause problems, but still, like ice packs, you have poked with the needle and hematoma happens or patient cries with pain, we usually keep the cryotherapy, that is ice packs, which reduces inflammation. And among thermal therapies, whether it is hot or cold, it depends upon the patient choice. But what we have seen is cryotherapy, that is ice packs, offer more restorative and therapeutic effect, while topical heat limits its only palliative effects. Nowadays, actually, one or two companies have come out with the lignocaine jellies. They apply before the poking of the needle, and it reduces the pain. Many of them we give local anesthetic needles. See, even when we give injectable local, that is also a needle itself. So, but with the insulin needles, probably the intensity of pain comes down. So these are the some of the way how we non-pharmacologically we manage the pain. Next slide. Then, which are chronic pains, especially muscular pains, even after dialysis sessions, they go home. So, what modalities we can do with the help of a physiotherapist? We can take their help, and we can include transcutaneous electrical stimulation, that is called as TENS, or topical thermal therapy. I already explained, but highly specialized physiotherapy equipments are there, or ultrasound are there, depending upon which area or feasibility of or tolerance of the patient. These things are also being used. TENS has been proposed to be beneficial for both acute and chronic pain, and it is probably most effective for post-operative pain or osteoarthritis and chronic musculoskeletal pain. Next slide. Then comes other what you say complementary or alternative medicine. They have recognized 6 categories under this. One is mind-body interventions. Now, how do they do it? They just give counseling how the mind approaches the pain, how to bring it down, calming off with multiple counseling sessions, and they're what you say giving them little stretching exercises or day to day what you say behavioral modifications. Then diet I am really not much what you say expert in how diet can reduce the pain, probably especially in patients who are having oral ulcers or candidiasis or vitamin B12 deficiencies and all. Probably the sensation. See, majority of our patients, they say, "Uta means I don't like having food." Probably because of when we dig deeper, when we see multiple ulcers or candidiasis or oral bad hygiene, probably we give a little spice, less food. Probably that might help in reducing the pain. Then it is a lifestyle modification. Give them little exercises, walking daily in the morning or 1 hour in the evening. Well, that will help much in reducing the pain. Then herbal remedies. We have seen multiple, what you say, house-made or herbal remedies you apply over the pain area, or that might have a, what you say, a remedy. Then manual healing like physiotherapy, or you have many of them go to Ayurvedic, what you say, treatment. Uh, they might get benefit, but you should be really careful while going to get those. I have seen many of them going for panchakarma massages and all, and coming back with the fractures because the bones will be very brittle to some extent. So you should be knowing how much you have to undergo all this treatment. Then electromagnetics and pharmacological biological treatments. All these are some of the methods in which pain can be limited. If See, what happens is anyone who is on dialysis, many times pain, it's not evaluated itself. I have seen many patients having a disc, a slipped disc, compressing on spinal cord. See, they should be treated like how others are treated. Once surgery is done, almost the pain, discectomy is done, the pain disappears. And we probably, the surgeons or orthopedists, they have a what you say hesitancy in operating patients who are on dialysis. That should not be done. Those who have got fractures, micro fractures, they should be given proper surgical treatment. then it's only time how you can reduce the pain. Then comes yoga, spirituality, and clubs or groups. All patients who are having similar pain get together. See, what happens is when you share your pain, it reduces. Oh, the other people are also having similar pain. It's majority of the time it is anxiety. If you have chest pain every time on dialysis, you hear that others are also probably having that. Just by sharing your experience, it reduces the pain. Or your home remedies, or how one fellow has overcome that pain. Hearing that itself can overcome these pains. Next slide. Now, this is for those who have social, psychological, or physical factors or familial factors. They might contribute to their psychological this thing to pain. It should be identified and sent to psychiatry such that they get a better perspective. And coming now to pharmacological, this I am just giving a very little importance actually. WHO has stated that step ladder pharmacological management. Basically, this was given for oncology patients, but we can extrapolate this to our renal guests also. Next slide. So this is how for doctors or even for our dialysis therapist, I usually tell, because many times we may not be the first, doctors may not be the first line pain management people. Depending upon their pain scores, probably with the help of a local physician or local doctor or even nurses, we can give a few over the counter or prescribable medicines to these patients who are really suffering from pain. Okay, next slide. Yeah, probably I'll end my small talk giving the broader outline what is pain, what are the types of pain, how patient presents with pain, what are the ratings, how we can give for the pain, and non-pharmacological or pharmacological aspects of pain. So I'll be happy to take questions if any questions are there. Thank you.
Yeah, thank you, Dr. Santosh. It was indeed a very interesting session, and how to manage the pain. So there are a few questions that I wanted to ask.
Yeah.
That people have asked. One of the
Yeah.
question is, hello sir, I am under dialysis, but still I'm facing digestion problem and not able to eat food properly. Kindly response.
Yeah, that is what I just said. See, many of
Yes.
them might have a language problem also. Someone said speak in
Marathi.
Marathi.
Yeah, yeah, it's
Marathi a little bit. I can speak in Konkani actually, but not in. I'm not very versed in Marathi. But pain in every language is same. Anyone who comes with pain, no, whichever language you say, it is almost same. So now coming to this gastrointestinal, so it is one of the commonest feature. Now forget about our dialysis guests. Even in common people also we find this because of our diet, timing of diet. What I usually suggest is they take their diet history. What time do you have your morning pills? What time do you have your morning breakfast? What time you have your afternoon lunch, evening snacks, or night dinner? First, you have it in regular intervals. That itself will bring down your gastrointestinal problems. If that doesn't help, you can have medical help also. Before that, go into depth. Why exactly you are having this problem? Because see, I cannot give a broader what you say treatment. What I feel is probably polypharmacy can cause gastritis. Whether you really require all these medicines, first you should go to your doctor and check it. Whether you are having gastritis or oral hygiene, whether you have got candidiasis. See, these small things now we try to forget. Whether you have vitamin B12 deficiencies. Many of what happens is majority of the time you just give pantoprazole and tretidine or some sucralfate syrup. That is all time limit. Probably he must have also had all these things for constipation, laxatives. But I advise go to your nephrologist when he is really free and try to address it. Because what happens, you go in a busy OPD, I always see, or when the doctor is very busy, no, we usually, the gas, you just write some prescription and send. But I personally feel whenever he is free, just go and meet him and you will definitely get an answer for your problem.
Sure. Thank you, sir. So there are more questions. Second question is pain more prevalent in hemodialysis or peritoneal dialysis patients?
I didn't get you.
Is pain more prevalent in hemodialysis or peritoneal dialysis patients? Like,
See, pain related to dialysis, probably this pricking pain of needles, each person has different types of perception. That definitely in hemodialysis it is much higher because you don't have needle pricking in peritoneal dialysis. Second thing is this cramps because it depends upon the patient himself. You drink more water when we try to remove in that 4 hours, definitely you'll have more cramps. But in peritoneal dialysis, it is not like that because even if you have more water, you are having ultrafiltration but when it comes to peritoneal dialysis, if you get an infection, it will definitely show what pain is. So that also has multiple. So it's not that hemodialysis or peritoneal dialysis. Other pains are almost similar in both the dialysis. If you are afraid of needle, peritoneal dialysis is better, but infection definitely can cause much more pain. Other than that, I think both are almost similar.
right. Sure. So, next question is, how do conditions like diabetes, bone disease, or neuropathy worsen pain in dialysis patients?
See, what happens is diabetes, what are all other conditions where you get
Diabetes, bone disease, or
yeah,
neuropathy?
yeah, almost all are similar. What happens is for when you different it from when you have a differentiation between normal patients having similar pain and dialysis patients having similar pain is dialysis patient will have little more threshold for the pain because uremia is also involved. Uremia means, see, whatever said and done, let it be peritoneal dialysis or hemodialysis, it has a limitation. We don't remove almost all the waste, that too within 4 hours. So, and majority of the waste we don't know. That is why we should thank God that He has made such a wonderful kidney that unknown toxic materials are also removed. That may not be happening in hemodialysis. So that is one of the reason probably the pain threshold or pain, the reason of pain in dialysis patients are more. But having said so, if you tackle step by step, like how I just explained,
Right.
each pain, probably it should not be much difficult.
Sure. And does changing dialysis duration or frequency help reduce pain?
And definitely, say if you, I have seen that twice a week dialysis patients comparatively prefer worst in pain management or than the thrice because the thrice you are removing more uremic toxins, you are removing a considerably good amount of, means a really a reliable amount of water, unlike how twice a week because twice a week if your weight gain is 4, definitely we cannot remove 4 liters that itself, and the technician tries to keep 4, you will starting within second hour or third hour you'll start getting cramps.
Mm.
You got my point, unlike those who are getting higher frequency of dialysis. So I feel more the dialysis it's much better, excluding pain of needle prick or
Okay. That's, I think, it's also very advisable to have at least 3 times in a week dialysis
exactly,
for these patients. Well
exactly,
noted,
exactly.
sir. So, next question is by Miss Neha. She says that my mother is 13 years old, 13 years on dialysis, non-diabetic BP patient, and she has become sensitive to touch, spinal cord pain,
Mm,
numbness, burning sensation in legs, facing
mm.
mobility issues, unable to lift leg. How to improve her condition?
This is exactly what I said. what happens is anyone who comes with the pain, no, we don't think that they can have, means our dialysis guests. We don't, means none of them think that they can have other than kidney disease. You might be suffering from a spinal disease. My usual most common things are your disc prolapse or anything related to spinal thing. I think you should meet a, neurologist or a spine surgeon to evaluate properly. See, if I tell stories, no, I have seen our patients who are on continuously telling pain, similar pain like what she's telling. And
Hmm.
I just did an MRI. We found a huge abscess. Once we did a surgery, no, she was totally all right, walking on her this thing. We have found tumors. We have found disc prolapses are very common in a normal fellow who suffers. We do operate them, no, we try to do, we don't tell them to wait with medicines. So I think evaluation is missing in her mother's condition. That to 13 years everyone will tell, ah, it is because of kidney, it is because of dialysis. May not be so. Better to go and meet a spine surgeon or a neurologist, at least do investigations and pick it.
Sure. I hope, Miss Neha, you've listened to what Dr. Santosh has said. Please take appropriate action. Sir, next question is, sir, may I know why does fistula hand pain more? Asked by Aisha
Yeah.
Sultana. Yeah.
Say what happens is fistula actually we have created because we want a good volume of blood for the dialysis. Now we are bypassing artery to and communicate, and we communicate it to the vein. Now, if the evaluation is not done properly, what happens is there is something called as a steal syndrome. The arterial blood goes towards the vein, and the rest part of the limb will be deficient of the blood. So that has to be evaluated. Otherwise, no, that limb will atrophy. So that is one of the reason you go to a vascular surgeon or to a nephrologist, they can pick it up. That is one of the reason why fistula hands pain. And because of high blood flow over the years, no, they might have little bit of more pain. Sometimes because of repeated pricking, they have venous stenosis in their neck or in their hand. So all this can be tackled if the fistula care is done properly. So what happens once fistula is done, if it is working, we keep on pricking. None of them are evaluating the fistula. Probably once in 6 months, dedicated AV, or once in a year at least, dedicated AV fistulas has to be evaluated, starting from neck till the end. How the blood is flowing, the amount of blood, is it good or bad? Especially for dialysis technicians, no, they should evaluate, and if there is a warning sign, they should send it to the nephrologist.
Sure. Thank you, sir. Sir, there was one question from Facebook. I just will read out. Hi, I am on dialysis. It has been 4 years now. Days I'm experiencing pain in my chest and shoulder. It's not healing. It has been 10 days. So, what to do?
Just 10 days.
Yes,
Okay. How old is the patient actually?
we'll have to check with him, sir.
Okay. No, whatever said and done, if it is acute pain, no,
Sure.
better to get an ECG
Hmm.
and an echo, meet your doctor, might be unrelated to dialysis or kidney disease per se. If cardiac issue is resolved, then probably we can, because it's acute pain, 10 days pain, it was not there.
Yeah.
Then we can think about any musculoskeletal, if there was any trauma or just this thing, that is the second line of management. But if 10 days of chest pain, go. It is like for others also. If I have, God forbid, if I have a chest pain, first what thing I do is have a ECG, have a
Oh,
ECG, have a cardiac markers, have that too. We can't believe now anyone can get a cardiac disease. So just go get a simple ECG and cardiac what you say marker CKMB drop I. If it is normal, rest properly, no problem. It's not a huge problem. Next line might be musculoskeletal. 2 days of acetaminophen or paracetamol might do the wonders.
sure. Sir, there's one question. Hello, sir. I am a dialysis technician. Sometimes patients suffer from severe abdominal pain as soon as we return the blood and disconnect the patient and conclude the dialysis session. So, what should we?
Yeah. See, this is very difficult to say. What happened while returning the blood is okay, fair enough. Again, abdominal pain during dialysis might be of different reasons. One, pre-existing chronic gastritis or GERD, or this thing can cause sometimes mesenteric ischemia. Ischemia means blood supply. When we are removing blood to the machine, no blood supply to the intestine, or it might be little deficient because of blockages in that. I think if it is only for one patient, he requires evaluation. If it is for all of them in that center, then think if at all they are reusing it, you are not washing it properly, or you are giving something which is causing water quality. All these matters. If it is for everyone, if it is for a single patient or episodic, not always, that patient requires evaluation.
Understood. So there's one question. Good afternoon, sir. Can suggest injection Dynapur AQ for CKD guest?
Yeah. See, now what happens is, if you ask me personally, almost now around 2008, around 20 years, I am in nephrology now. In that, no finger, okay, you can count in fingers. I have written NSAIDs or diclofenac for few of them when the pain is not tolerable at all. For normal individuals, I don't write at all. That is one, because we see it might be a bias. But in dialysis patients, when pain becomes unbearable, probably one or two times I might have written because of trying all other methods. Why we don't write diclofenac is, even though you are on dialysis, you have some residual renal function. Some amount of urine will be going, some amount of it, which might be helpful in your water, what you say, intake, or it might be helpful for the removal of those toxins which we still don't know. So you give chronic, you take chronic NSAIDs, that is diclofenac, all those things. Rest kidneys are also short. So this is my personal opinion. This is my personal opinion. I usually don't give diclofenac, or I usually tell the patients not to take. But having said so, if pain is unbelievable, means cannot tolerate, especially as inflammatory osteoarthritis, or I will not say osteoarthritis, something like multiple joint pains and all, and that is the only medicine, then you can't help. Probably you can give because already you are on dialysis. So some of the nephrologists liberally give, but usually I have seen nephrologists not giving diclofenac. Majority of them try to avoid. Even one nephron, I am there to save it.
Sure. So next question is by Tarun Bhomik. He says, how to understand different types of abdominal pain, like gastrointestinal pain or stomach cramps and others.
No, see, it is very difficult even for the doctor also to know how to differentiate. But clinical exam, its history, clinical examination and investigation definitely will, probably this is little left to the doctor than the patient himself. Otherwise, you try to Google, no? The first cause for stomach pain is stomach cancer. You just Google
Yeah,
and see.
correct,
You
correct.
got my point. So
Yes.
it becomes totally absurd. So I think if such kind of thing is there, it's not only history. Probably I would like to have a detailed history. Second is examination also. Then probably ultrasound or some investigations which will lead to the cause of pain. Unless just shooting out telling just abdominal pain.
Okay. So there is one person, K.S. Sunil Kumar. He has written heavy, and there's a word in, I think, Kannada. I'm not able to read that.
Can I see that?
Yes, yes, it's there in the webinar chat, so.
1 minute.
There's pain after dialysis and then joint pain.
1 minute. Dynapur I saw. Mother is 13 years over. blood checkups. Heavy body pain.
Okay, body pain.
A heavy body pain after
After
dialysis,
dialysis.
also joint pain. Yeah, that is what.
That
See,
we have answered.
again, same. Why body pain? Because probably the amount of water removed is more, or the weight gain is more. The ideal weight gain, if at all you have thrice a week dialysis, should not exceed 1.5 to 2 liters. Then probably you may not have this severe body pain. But if the technician removes more than two or three or four, definitely will feel exhausted, and that is one of the reason. Second, probably your medications. Usually we give calcium supplements or vitamin D3 supplements, phosphorus binders. Well, all those things might be one of the reason why having body pains after dialysis. Even single-use dialyzer sometimes can cause, that's called as first-use syndrome. So probably I think he has to talk to the concerned doctor to know
Right.
exactly why pain is.
Sir, after I think with time, the body pain kind of lessens, once the body is also adjusted with, dialysis sessions. I mean, I'm just guessing.
Yeah.
So next question is by Miss Neha. She says role of denosumab for osteoporosis in dialysis patients.
Uh, See, it is a what you say, newer drug actually. I usually what I do is take an opinion of an orthopedician, to be frank, even in dialysis patients, whether it can reduce the pain or reduce the risk of fractures. And if they really feel it can be given, we have given, but I don't use denosumab, to be frank with you. So I cannot give, because the category which I treat here are more of below poverty line patients, and cost is the thing, and repeated is. But I have given denosumab to a few of my patients, and it has worked well to them. So I would not tell category, because see, that's what osteoporosis, how to diagnose it. Just giving denosumab may not help. You have to have a proper diagnosis, get a bone DEXA scan, and actually no, the gold standard diagnosis for bone disorders in kidney disease is a bone marrow. Hardly we do it actually. So bone marrow, and it's very painful investigation. So that's the reason I usually take a orthopedics physician's help. When once they evaluate, when many of the times, no, with just phosphorus binders, vitamin D3 supplements, the pain comes down. But if in resistant osteoporosis, especially females, there might be a role of denosumab. That's what I can comment now.
Sure. So just two last questions and then we'll be done for the session. One
Yeah,
is uh, I am 28 years old and I'm suffering dialysis in 3 years ago. After dialysis, why stomach pain? Asked by Nanda, but I think we have so many times
yeah,
discussed this.
yeah, yeah.
So I'll let this go. So the last question for the session is, can we give injection levocarnet 1G for several muscle cramping during dialysis?
Yeah, same thing. See, it is also something like a placebo, to be frank. But what studies shows or literature tells, it might have some benefit, because we also use resistant people, resistant cramps during dialysis. May have been, there is nothing harm in trying it. At least it doesn't have much side effects. So can try, but I would actually try to address this problem. Why cramps? Mainly it will be because of water removal. That means weight gain and water removal. Concentrate on that. Probably it might give an answer. You, despite your water, this thing is controlled. I think can be tried. But categorically to say that everyone should receive levocarnitin, no, I would not say that's correct. Yeah. No, I can't hear you. You are mute.
Oh, sorry. Sir, I'm saying that while you answered this, there are two, three questions, and people
Yeah,
just
yeah,
popped
we
up
can
in
take
the.
it, no problem.
Yes. Sir, he's saying that what will be better for cramps, sir? Amino acid infusion or levocarnitine?
All these, see, off record, I can say all these are experimental ones or similar to placebo. It's very difficult for me to tell, ma,
Oh,
because
okay.
nothing is proven beyond doubt. Otherwise, we would have been using this left, right, and center. No?
Hmm.
And when it comes to cost benefit, I don't know. If someone is affordable, we can try and see which acts better. To be frank, I don't have much experience in giving this also. Levocarnitine we give, acid infusions, usually we limit it to acute care actually. Very rarely we do it, to be frank.
Sure. And sir, one last question by Miss Nagina. I am not able to walk properly. If put pressure, my legs will swell. I was walking normal before 6 months. Since dialysis started, I'm unable to walk. Please help.
Yeah, this probably say what happens is machine doesn't understand which to remove, which not to remove. It removes almost all nutrients also. I personally feel she might be having vitamin B12 deficiency or
Hmm.
something like that. You should meet your doctor, get thoroughly evaluated. I think with supplementation of vitamins, your condition might be improved. That is one of the reason, or probably something related to your spine, or it must be treatable one. Go and meet your doctor as soon as possible.
Sure. Thank you, sir. So before we end this session, just request if some two or three very crisp points that you can give to our dialysis patient who's watching us online so
Yeah.
that they are in their everyday life able to manage their pain. Some very easy hacks or tricks.
Yeah. No, what I usually tell patients is uh, if pain is very acute in nature, suddenly it has come, definitely it requires what you say assessment. It cannot be, it should be because of some reason. If it's a chronic pain and you have got evaluated and it's not coming down, change your lifestyle. Don't go behind the pain. It might be related to your psychosomatic illnesses also. So change your lifestyle, get some exercise, go for a walk, and what you say, life is much beautiful actually. So try different ways, have some hobbies. Probably that might bring down majority of our pain. Take it from me. Spirituality, yoga, all these things help. Have good friends, talk to each other. Majority, see, our it's like a normal person. You are not different by just going being on dialysis. Now, how do normal person, if he is in pain, how does he express? Talk to the. So I think being on dialysis is not at all a problem. It's not what you say. You can lead a very normal life. You should be happy in life. Go talk to your doctor, to your counselor, to your family. Be like a normal fellow. Try to earn. Also go to work. All this is what I can tell. Be like a normal person. That's what I actually tell. When I met Kamal Shah, also I had told I will translate your book, what he has written,
Hmm.
in multiple languages, especially, and it should be available in all dialysis centers. Or when you when a patient is initiated on dialysis, no, when he comes to the dialysis facility, whichever lab, whatever, whichever, they should read that book. That itself will give. See, I don't have shame in telling that I'm much inspired by him actually, because having if I was in his position, probably I would not have gone through so much of thing, starting a company for those, and now also leading a normal life. No, it takes. So I don't know. He has not given us permission also, at least in Kannada or this thing. I wanted to, because that reading that book itself, no, will give you much courage to face the what you say life. So that's the reason we had called him to our facility here. We were much honored. He had attended a program here, gave his small talk, met with all, I think almost 400, 500 technicians were there, means budding technicians actually, and they were all impressed by his this thing. And that is how we should go ahead, not thinking it is as a burden.
Sure. That's a very useful piece of advice, sir.
Yeah.
I hope all the guests that are
No, you
watching
should
us,
tell that his book should be available everywhere actually,
sure, point taken, sir.
and in different languages.
Sure, sir, point taken.
It is
We'll
written
try
in
our best.
English. Majority of our patients may not understand. So
Yes.
I think in all local languages. See, now even a film releases in different languages.
Sure, sure.
So
Sure, sir.
that is
Yes.
how it works. Okay. Yeah.
Sure, sir. So, but I hope the guests who are listening us are motivated enough to start a normal life.
Yeah.
We have been, it's our mission to enable people on dialysis to live a normal, productive life. On this note, doctor, I would take your permission. We would
Yeah.
like to end this session and thank you for this amazing session.
Yeah.
Honestly, it was quite a learning curve for me, to understand what pain is, what are the causes, and how do especially the dialysis guests can manage their pain. It will help in their everyday lives. Thank you, sir. I'll see you in the next
Yeah.
episode.
Yeah. Thank you. Thank you very much. Thank you.